Assalamu alaikum. Today we are going to talk about extractions using an elevator. One of the best elevator design that I've seen is the one with bin angle into it. Normally the elevators are pretty straight and you're supposed to try to take out the tooth with it. Uh, this is a wonderful elevator. We got it made here with good serrations on it. This one is a one design where the serration is on the outside of the elevator. But we also have elevator where the cup is the other way and the serrations are on this side. And I get to use them on lower wisdom teeth particularly with very good results. And the concept is to have a bin angle elevator. And with this, when you put it in between the teeth and you twist it, you get a lot of fulcrum action and good force creation. And the serrations on the elevator, the cup side of the elevator provides engagement into the root surface of the tooth and elevates the root out very nicely. One of the examples which I would show you where we use it for extraction of the teeth is in the maxilla. You go in at a 45-degree angle to the face. So you don't go straight up, you go from the side of the cheek and you have the patient close down a little bit. In the beginning, you have the patient open up the mouth, put the elevator on the distal of the second molar at this angulation, and then have the patient close down the mouth. Once the mouth closes down, then you're able to slide the elevator inside and keep twisting it. As you twist it, it pushes the wisdom tooth distally, and you keep on going further, and eventually you twist it completely and you rotate it. That would elevate the tooth downwards and you see it pop out. Now, if this tooth is totally covered with soft tissue, what I would do is I would take a periosteal elevator and slide it slightly to the distal and hold it there with my left hand, and as I work on the right side to pull this tooth down. And the reason is that the reason I put the periosteal elevator white and on the distal aspect is to allow for the tooth to slide down on the periosteal elevator and also to prevent it from sliding back up into retromolar space area up on the top in the maxilla. We don't want that to happen. On the lower arch, you do the same thing. I would section this tooth right here and elevate one part out and then elevate the second part out, and this elevator works wonderfully. In a later video we will show exactly on how to do an extraction on either a cadaver model or on a live patient, and we'll put this on the YouTube channel. Now here's an example. Sorry, this was upside down, but we are looking at a second molar region, and I'm giving an example of the first molar extraction. First molar is the tooth that comes out into the mouth when the patient is only 6 years of age. Hence, it is more likely to have decayed later on in life and needs most number of extractions. And also we know it's a first molar that needs upper or lower, that needs most RCTs to be done because the patient has had it since 6 years of age, and it's also the tooth which is commonly most missing in the mouth, and that's where you need to end up doing an implant. But anyhow, in case you come across a patient in which the tooth is fractured like this, what you'll see is a palatal root on the radiograph, a mesiofacial root, and a distal facial root. So you'll see 3 roots in there. And the concept would be to go inside and elevate out each root at a time. I would like to take out the palatal root a little bit, leave it in there, and then take out the other 2 roots and eventually pop out the palatal root to gain momentum and to gain some support as I'm elevating the teeth. So I'll show you the occlusal view of it. So here would be the occlusal view of the same area. What you see is the second molar and the second premolar, and then you see these 3 roots broken down. So what I would do is, if this is the maxilla, facial, and the lingual, I would go inside right there and push the elevator inside and start rotating it. As you're rotating it, you have to realize that you're pushing the elevator into the PDL space right next to the root that you want to take out. And you can take a little bit of support from the adjacent tooth. Since this area of the elevator is nice and rounded, it won't hurt the adjacent tooth, but you keep pushing it, and you have to make sure you keep your finger fairly close to the end. So in case you slip, you don't puncture the chin or the cheek anywhere. And you push it in and you keep rotating it. As you keep rotating it, you will realize the elevator keeps on moving further and further deeper, and with a little bit more rotation from the facial aspect, you'll be able to pop this root out. You do the same thing here, and you rotate that one out, and you do the same thing on the palatal. What I would do sometime is I would go in between the roots, rotate that, loosen that a little bit, loosen this, then turn around the elevator, loosen the palatal root. The key would be to loosen all 3. If you take one root out completely, then you cannot use that root as a fulcrum point or a support angle to loosen the other ones. So the point here is use this elevator and the adjacent teeth to loosen all 3 roots. That way you know they're there and you take them out. Worst come worst, if something is loose and you're not able to pick it out, pick out an endodontic file Number 25 works great. It's the one with the red handle, and you'll be able to see the open pulp chamber and the nerve canal. You take your file and you screw it in. It engages the root, and then you pull out the root with it. It's very simple to do, and you can take out all three after you have loosened them a little bit. Elevator, this kind of elevator works wonderfully for that. Now, when it comes down to lower teeth, here is an example of the lower molar. It's the mandible, second molar, second premolar, again, first molar broken down with two mesial roots, mesiolingual and mesial facial, and then you have a large distal root. And you would do the same thing. You take the elevator inside, and you can go interradicularly also and loosen the roots, all three roots. When the roots are loose, like right here, these are the mesial roots, you loosen both. You can use the adjacent tooth for support to loosen from this side. And then on the distal, engage it right down the middle of the root and start rotating in, and make sure you hold your finger very close to the tip. So in case you slip, you don't go into the lingual aspect of the mandible, and you don't puncture the lingual floor of the mouth, or you don't puncture the buccal vestibule of the patient. And once all these three are loose, then you should be able to pick them out with the same elevator, and the serrations help you do that. In case the root is loose but it doesn't come out, quickly go ahead and grab a number 25 or number 30 file, endodontic file, go into the pulp chamber, screw the file in, engage it, and then pull the root out. It comes out real nice. I hope that clarifies a lot of issues.